Good afternoon. I'm very grateful to the organizing committee for this opportunity to summarize the most up-to-date evidence regarding the effect of GLP-1 receptor agonists on blood pressure. And let me start by saying that GLP-1 receptor agonists were launched back in 2005. Exenatide was the first agent to be introduced in clinical practice. Since then, several molecules of the same drug class have reached clinical practice, virtually transforming the landscape in the management of type 2 diabetes. In fact, the indication of GLP-1 receptor agonists has expanded to include management of obesity and mitigation of cardiovascular risk as well. So arterial hypertension and diabetes often coexist, and the presence of hypertension amongst patients with type 2 diabetes confers excess risk for microvascular and macrovascular complications. Both conditions share the common phenotype of the metabolic syndrome, and it is well known that for every 10 millimeters mercury decrease in mean systolic blood pressure amongst individuals with type 2 diabetes, a 12% reduction in all-cause mortality is to be noted, along with a 12% lower rates of myocardial infarction and a 9% decreased incidence of stroke. Nevertheless, despite the availability of multiple antihypertensive agents, blood pressure targets are rarely reached in as few as 50% of individuals with type 2 diabetes, especially elderly people for whom polypharmacy is a big issue, let alone the drug acquisition costs. So in the next few minutes, I will try to summarize the evidence from randomized trials and systematic reviews and meta-analysis thereof regarding the effect of GLP-1 receptor agonists on blood pressure, and I will show you also data from dedicated blood pressure trials utilizing ambulatory blood pressure monitoring. I will also try to delve into the mechanisms underlying these blood pressure lowering effects of these agents. And I will also have a look into the future, which looks quite bright in this area, with the recent introduction of the dual GIP-GLP-1 receptor agonists, such as tirzepatide, or other agents that are in the pipeline. And let me start by presenting the clinical evidence in support of the blood pressure lowering effects of GLP-1 receptor agonists. This is a network plot from a previous meta-analysis conducted from our group that Thomas showed you. These are data from more than 250 trials in patients with type 2 diabetes, including more than 250,000 people with type 2 diabetes. And as you can see, all major antidiabetic classes and individual agents are represented in this graph. Each node in this graph represents a drug class or an individual antidiabetic agent, and the size of each node is proportional to the evidence regarding this specific drug class or agent, whereas the lines between the nodes and the thickness of the lines represents the number of available comparisons for this specific drug class or antidiabetic agent. So based on these meta-analytic findings back in 2019, last search was run on December 2019, the SGLT2 inhibitors class is the most efficacious for reducing the systolic blood pressure. Nevertheless, several GLP-1 receptor agonists do also confer modest benefits regarding systolic blood pressure reduction. As you can see, semaglutide, exenatide, liraglutide, and dulaglutide do have an effect on systolic blood pressure in the order of magnitude of 2 to 3 millimeters mercury, and the confidence in the effect estimates is actually quite high, moderate to high, as represented by the blue and the green color respectively. We did not note a similar effect on diastolic blood pressure. Again, SGLT2 inhibitors were the most efficacious drug class for reducing diastolic blood pressure, but a statistically significant effect was seen only with a minority of GLP-1 receptor agonists, such as exenatide or semaglutide, most of the other agents of this class did not have a statistically significant effect on diastolic blood pressure. These are data deriving from office-based blood pressure measurements. And of course, the picture is different. Thomas also showed this graph before. The picture is different regarding the effect of these medications on body weight. In this context, GLP-1 receptor agonists are represent the most efficacious anti-diabetic drug class for reducing body weight, and subcutaneous semaglutide administered on a weekly basis was by far the most efficacious agent. So thereby this suggests that there might be a weight-independent mechanism that could explain these blood pressure lowering effects, mainly for systolic and to a lesser extent, if any, for diastolic blood pressure seen with GLP-1 analogs. On to some primary research evidence. This is an investigator-initiated trial conducted by our group a few years ago. We tried to ascertain the effect of liraglutide on the ambulatory blood pressure profile. This was a comparison against placebo, a multi-center trial across 7 study sites in Greece. And these are the main findings of the trial. As you can see, liraglutide reduced systolic blood pressure by 5.73 millimeters mercury. And this change was mainly driven by daytime measurements. Nevertheless, we did not detect a statistically significant effect of the drug on diastolic blood pressure. As you can see, slight decreases in diastolic blood pressure were seen with liraglutide, but placebo-subtracted changes did not reach statistical significance. And notably, we identified a positive chronotropic effect for this drug. Liraglutide increased mean 24-hour heart rate by 6.16 beats per minute. And this positive chronotropic effect was sustained throughout the day relative to placebo. Let me open up a parenthesis in here to discuss the potential for an increased incidence of tachyarrhythmias with GLP-1 receptor agonists. These are meta-analytic findings from 8 major cardiovascular outcome trials with more than 60,000 participants. As you can see, cardiovascular outcome trials for all major GLP-1 receptor agonists are represented. So this meta-analysis showed that no increased incidence of tachyarrhythmia is to be noted with GLP-1 analogs. And the same holds true for several arrhythmia subtypes, such as atrial fibrillation, atrial flutter, ventricular arrhythmias, or sudden cardiac death. So despite the positive chronotropic effect, no increased incidence of tachyarrhythmias is seen with these agents. Now on to another dedicated ambulatory blood pressure trial with another GLP-1 receptor agonist, namely dulaglutide. In this placebo-controlled trial, 755 patients with type 2 diabetes were included back in 2014. And as you can see, after 26 weeks of treatment with dulaglutide, participants experienced marginal reductions in systolic blood pressure in the order of magnitude of 2 to 3 millimeters mercury, which did not reach statistical significance. So this was actually a negative trial for liraglutide. And yet again, this is probably a drug class effect. An increase in 24-hour heart rate was noted after exposure to liraglutide of approximately 3 to 4 beats per minute. What about the newer GLP-1 receptor agonist tirzepatide? These are pooled results across the SURPASS clinical development program of the drug, which showed that tirzepatide was associated with reductions in systolic blood pressure ranging from 4.7 up to 12.6 millimeters mercury across the clinical development program for the highest tirzepatide dose of 15 milligrams per week. And unlike meta-analytic findings, which are based on blood pressure measurements in the office, Meta-analytic findings based on 24-hour ambulatory blood pressure monitoring have so far provided mixed results, but as you can see, a limitation of this analysis was that not all GLP-1 receptor agonists were represented. Back at that time, evidence from ambulatory blood pressure trials were available only for liraglutide, dulaglutide, and twice-daily exenatide. So what are the potential underlying mechanisms that could explain these blood pressure lowering effects of GLP-1 receptor agonists? This relatively old meta-analysis conducted back in 2014 by Katut and colleagues tried to explore the relationship between weight loss and blood pressure reduction with GLP-1 analogs, utilizing meta-regression analysis. In this analysis, 32 trials with 12,469 participants were included, and the main finding from the meta-regression was that the degree of weight loss did not fully predict blood pressure reduction, thereby suggesting that there might be some weight loss independent mechanisms that could explain this favorable modulation of cardiovascular risk seen with these agents. Again, another limitation of this analysis as well, conducted back at that time, was that only trials of exenatide and liraglutide were included. In the meantime, several other mechanisms beyond weight loss have been proposed to explain the blood pressure lowering effects of GLP-1 analogs, such as increased natriuresis, either through increased release of the atrial natriuretic peptide or through decreased sodium reabsorption in the proximal convoluted tubule. For example, there is animal research evidence that shows that the GLP-1 receptor is actually expressed in porcine tubular kidney cells. Other potential mechanisms include a reduction in the sympathetic nervous activity, a decreased vascular resistance through release of nitric oxide in the endothelium, or lower levels of angiotensin II. Back to our investigator-initiated trial, which assessed the effect of liraglutide on the ambulatory blood pressure profile of hypertensive patients with type 2 diabetes. We also incorporated a small mechanistic part trying to decipher the effect of the drug on renal sodium handling, and we used lithium. We administered participants lithium, which is absorbed in parallel with sodium in the proximal convoluted tubule, in an attempt to gather more information about sodium handling in the nephron. Nevertheless, we did not see statistically significant differences in sodium excretion between the liraglutide arm and the placebo group, and lithium excretion was also similar between the two groups of the trial. However, I have to say that other trials with these specific agents have identified the potential natriuretic effect mainly after short exposure to these GLP-1 analogs. What about semaglutide, which is actually more potent in terms of weight loss? These are the results from a mediation analysis conducted across the clinical development program of semaglutide titled SUSTAIN. A mediation analysis is a type of analysis that tries to explore the relationship between a dependent variable, in this case, the effect on systolic blood pressure, and an independent variable, in this case, weight reduction, body weight reduction. So the degree of weight loss did actually, seen with semaglutide, did actually predict the extent of blood pressure reduction, but even for participants, for the minority of participants exposed to semaglutide that did not experience a blood pressure that did not experience weight loss, a blood pressure benefit in terms of systolic blood pressure reduction was still evident and was even more than 5 millimeters mercury. Again, raising our curiosity, what is this underlying mechanisms that drives this change in blood pressure beyond weight loss? And what about the newer agents that have been recently introduced in clinical practice or are currently in the pipeline, which are also more potent in terms of weight reduction? Let's have a look at a dedicated ambulatory blood pressure trial with a GLP-1 receptor agonist tirzepatide. In the SURMOUNT-1 ABPM study, almost 500 overweight or obese participants without diabetes were enrolled. And as you can see, tirzepatide was associated with reductions in systolic blood pressure ranging from 7.4 up to 10.6 millimeters mercury, and the effect was statistically significant for all tirzepatide dose cohorts. Smaller reductions in diastolic blood pressure were seen with tirzepatide 5 and 10 milligrams per week, but not with the highest tirzepatide dose cohort. And yet again, a consistent finding, which has to be taken as a drug class effect, is the positive chronotropic action of this dual GIP-GLP-1 array. An increase in 24-hour heart rate was seen across all tirzepatide doses, ranging from 2.1 up to 5.4 beats per minute. Onto a mediation analysis, which tried to explain the blood pressure reduction seen with tirzepatide. As you can see, most of the blood pressure reduction seen with tirzepatide was mainly attributed to weight loss. Nevertheless, this correlation was relatively weak, thereby again suggesting that other mechanisms might be in play as well that are not yet completely understood. Systolic blood pressure reduction could not be explained by antihypertensive medication used at baseline. In other words, participants experienced the same systolic blood pressure reduction after exposure to tirzepatide, either they were using other antihypertensive medications or not. Participants belonging to the highest blood pressure quartile at baseline experienced the largest systolic blood pressure reduction, whereas participants belonging to the lowest blood pressure quartile at baseline did not actually see a benefit in terms of systolic blood pressure. And to me, the most interesting finding was that tirzepatide 10 and 15 milligrams per week was superior to semaglutide 1 milligram per week for systolic blood pressure lowering. Change in systolic blood pressure was 5.3 and 6.5 millimeters mercury for tirzepatide 10 and 15 milligrams per week, respectively, versus 3.6 millimeters mercury with semaglutide 1 milligram. These are results from a pooled analysis across all tirzepatide trials in the SURMOUNT clinical development program. What about a triple hormone agonist? Retatrutide is a GIP, GLP-1, and glucagon receptor triple agonist, for which this recently published trial within 2023 in the New England Journal of Medicine showed an impressive body weight reduction up to approximately 24%, which is comparable only to weight loss achieved by metabolic surgery. As you can imagine, metabolic surgery is not scalable. So this observation, if this drug finally makes it to clinical practice, will have profound implications for the management of obesity in daily clinical practice. Those were patients, adult patients with an increased BMI, but without diabetes. And in this very same trial, we have also some impressive data regarding the effect of the drug on the 24-hour ambulatory blood pressure profile. As you can see, retatrutide was associated with a reduction in systolic blood pressure that could be as high as 12.1 millimeters mercury. And for the first time, we also noted a clinically relevant reduction in diastolic blood pressure as well, up to 8.1 millimeters mercury. And what is also very interesting is that 41% of the participants in the combined 8 milligram retatrutide group and 30% of the participants in the 12 milligram retatrutide group were able to discontinue at least one antihypertensive medication. As you can imagine, this has profound implications again for clinical practice, especially for patients with type 2 diabetes and comorbid hypertension who are destined to use quite a number of medications and for whom polypharmacy is a major issue. We also have comparisons of retatrutide with dulaglutide amongst patients with type 2 diabetes, and these are results published in the Lancet within 2023. Again, here you can see that retatrutide was associated with a large glycemic benefit that even exceeds 2% reduction in hemoglobin A1C and was superior to dulaglutide in terms of hemoglobin A1C lowering. Again, the drug was very effective in reducing body weight. As you can see, the body weight reduction with the highest retatrutide dose cohorts was between 15 and 20%, and the drug outperformed dulaglutide 1.5 milligram per week, which is not very potent in reducing body weight, admittedly. And these are the effects of the drug on a population of patients with diabetes, with type 2 diabetes. As you can see, systolic blood pressure reductions were seen with all doses of retatrutide, and similar changes in diastolic blood pressure were seen as well in this population. Now, GLP-1 analogs are injectable therapies, and there is an unmet need for more convenient therapies for patients with type 2 diabetes. For instance, many patients are reluctant to use injectable therapy, so orforglipron is another daily non-peptide oral GLP-1 receptor agonist that is currently in the pipeline for the management of obesity and diabetes, and has the potential to increase acceptance of treatment, adherence, and persistence of use. Based on findings from this placebo-controlled trial with a duration of 36 weeks, conducted among 272 adults who were overweight or obese, orforglipron was associated with a 15% reduction in body weight. And let's have a look at results regarding blood pressure lowering. As you can see, all orforglipron dose cohorts were associated with significant systolic blood pressure reductions ranging from 6.7 up to 10.1 millimeters mercury, and slighter changes which did not reach statistical significance were also noted regarding diastolic blood pressure reduction. Again, a drug class effect is the positive chronotropic effect of the drug, which increased heart rate. And results were similar, not only in this cohort of overweight and obese patients, but in a cohort of patients with diabetes. As you can see, orforglipron was compared in this trial, published again in the Lancet, not only against placebo, but against dulaglutide as well. But placebo subtracted and dulaglutide subtracted differences with orforglipron dose cohorts regarding systolic and diastolic blood pressure reduction did not reach statistical significance for the most. So to sum up, it seems to me that the SGLT2 inhibitors class is or was the most effective anti-diabetic drug class for reducing blood pressure. Nevertheless, we have to bear in mind that most GLP-1 receptor agonists do also confer benefits mainly for systolic and to a lesser extent, if any, for diastolic blood pressure reduction. It seems that there are differences between individual agents regarding blood pressure reduction. Tirzepatide appears to be more effective than semaglutide, which in turn is more effective than liraglutide and exenatide. And available evidence does not fully support a blood pressure lowering effect for dulaglutide and lixisenatide. We are not yet sure whether body weight loss is only to be accounted for this blood pressure reduction seen with GLP-1 receptor agonists, or whether other mechanisms might be in play as well. And these data derive mostly from animal research and small mechanistic studies in humans. A consistent drug class effect is an increase in heart rate, which is seen with all GLP-1 receptor agonists and could be a possible explanation for the less pronounced effect of these agents on heart failure outcomes as compared with SGLT2 inhibitors. But the landscape is beginning to change with the advent of newer generation GLP-1 receptor agonists, and mainly triple hormone agonists, such as retatrutide, which offer impressive body weight reduction and have the potential to transform this field. A question remains whether a concomitant use of GLP-1 receptor agonists with a SGLT2 inhibitor could have an additive effect on blood pressure. And I think I'll finish with that. And thank you very much for your attention.